Okay, so for the next hour and a half, you're stuck with me. You're going to get tired of hearing me today because we have 3 parts to cover. So for about the next hour and a half, we're just going to tackle some cases. This is all going to be in a case format, so it's going to be low stress, okay? All right, so in this first session, which is going to be 40 minutes, we're going to do CNS infections, common viral infections, including HIV, and we're going to talk about TB, as well as non-tuberculous mycobacterial infections, all of which are very board relevant. All right, so the first case is a 9-month-old unimmunized child who attends a child care center, who develops high fever and lethargy. On the way to the ED, he experiences a 5-minute tonic-clonic seizure. In the ED, he has no further seizures, but is somnolent and lethargic. The LP shows 3,500 white cells, 90% of which are polys, a protein of 130, a glucose of 5, and the gram stain is pending. What's the most likely etiologic agent? Herpes simplex, pneumococcus E. coli, group B strep, or TB. And again, this is a 9-month-old. Okay, very good. So of the choices here, strep pneumo. So this gives us a good opportunity to look at CSF parameters in different types of infections. You have bacterial, partially treated, TB, viral, and parameningeal. The number of cells, as you can see, there's great variation, but in general, much higher with bacterial. Usually doesn't change much with partially treated meningitis. And then with TB and viral, it's usually going to be lower. And with a parameningeal focus, such as a brain abscess, it's also going to be lower. The glucose is low in bacterial. Again, doesn't change much with partially treated. Is low, especially later on with TB. Early on, it may be normal. Later on, it's going to be low. And with viral and parameningeal, normal. And the protein is going to be high. And all of these, mildly high with a viral process. The gram stain is going to be positive 90% of the time. The most common reason for a negative gram stain is with Neisseria meningitidis because the bugs are intracellular. You may not see them on gram stain. The culture is the gold standard for making the diagnosis. And remember, with partially treated meningitis, the gram stain and culture may be negative. Okay, the classic signs and symptoms you're all familiar with. Fever. Remember that children less than 2 years of age will not have a stiff neck. Mental status change, a full fontanelle. And again, in babies less than 2, it's nonspecific. They just look ill, and they may not have any specific focus on exam. So the pathogens with bacterial meningitis in newborns, again, group B strep, and E. coli, listeria, and then salmonella should be included in this list as well. After 6 weeks of life, again, the only bugs that you really need to worry about would be meningococcus and pneumococcus, and if somebody has not been immunized, then we also worry about H. flu type B. After head trauma, so if they present a case to you of classic bacterial meningitis following head trauma, the bug is going to be strep pneumoniae, okay, because that's the bug that most commonly colonizes the nasopharynx. And post-neurosurgical meningitis is caused by a hospital-acquired pathogen, so gram-negatives and staph, especially Staph aureus, including MRSA. So things like Klebsiella, Pseudomonas, and Staph aureus. So empiric treatment for bacterial meningitis in newborns, we generally like AMP and GENT or AMP and cefotaxime. And then after 6 weeks of age, you're mainly covering pneumococcus and meningococcus. And in those situations, cefotaxime or ceftriaxone. And remember to add vancomycin until you have susceptibilities because of the possibility of penicillin and cephalosporin-resistant pneumococcus. Remember, the vancomycin is for the resistant pneumococcus, not to cover for staph, which is an incredibly rare cause of bacterial meningitis. I wouldn't worry about durations for your exam. They're not going to ask you those. But generally, meningococcus we treat for 7 days. Once you know it's meningococcus, penicillin is perfectly fine. With H-flu, it depends whether it's beta-lactamase positive or negative, in which case you would use either ampicillin or ceftriaxone, cefotaxime. And with pneumococcus, we usually treat a little longer. For penicillin-susceptible strains, again, you can use penicillin or cefotaxime or ceftriaxone. If you have a bug that is not susceptible to penicillin, meaning it's intermediate or completely resistant to penicillin, then you can still use ceftriaxone because you can overcome the pneumococcal resistance. However, if you have a bug that is non-susceptible to a third-generation cephalosporin, then in those situations, we generally add vancomycin and we add rifampin. They're not going to ask you about this. These are very, very complicated cases, and this is where you really need an infectious disease specialist. Steroid therapy. These are the recommendations from the AAP that we consider only for children older than 6 weeks of age, so this is not for neonatal meningitis. And what you need to remember is that dexamethasone back in the 1990s was shown to be beneficial only in cases of Hib meningitis, which we no longer see. And what they found that in children with Hib meningitis who received dexamethasone at the onset of their therapy had a decreased risk of hearing loss. That's the dose right there. It must be given prior to or concurrently with the antibiotics. So once you've given the antibiotics, it doesn't make sense to give steroids after that. There is no recommendation for pneumococcal meningitis. So it's controversial whether you use corticosteroids for children with bacterial meningitis. We do not use them routinely, and because it's controversial, it's unlikely they're going to ask you this on a test. Remember that we use droplet isolation for 24 hours for hospitalized children who have Neisseria meningitidis or Hib meningitis. No isolation is needed for pneumococcal meningitis in the hospitalized child. So question 2 relates back to the first case. So the culture of the spinal fluid on that first case revealed meningococcus. So which of the following statements is true? Meningococcal vaccine should be given to all contacts at the child's daycare center. The occurrence of a seizure at the onset predicts a poor prognosis. The overall prognosis is better than if the child had meningococccemia without meningitis. Or rifampin prophylaxis should be given for family contacts of this child, but not for the child care contacts. Yeah, this was a little tougher. Wow. All right, so the right answer is C. The overall prognosis. Remember, a couple of days ago, I told you that it's better to have meningococcal meningitis than meningococcemia, okay? Because kids with meningococcemia don't have time to develop meningitis. They usually die before that, okay? So meningococcemia is fulminant septic shock, whereas kids with meningococcal meningitis, if they're treated appropriately, they usually do very well, okay? So again, these are the poor prognostic factors which I showed you a couple of days ago. So contact with meningococcal disease, very important that you know who to prophylax and when to prophylax. So children who are at low risk where no prophylaxis is recommended, so anyone who has indirect contact, casual contact such as work or school without contact with oral secretions, those are low risk. And healthcare personnel who do not have contact with oral secretions. These are all patients that do not need to be prophylaxed. In an outbreak or cluster situation, you always want to consult with the local health department for recommendations. But this is the important slide. These people need chemoprophylaxis when exposed to a child with meningococcal meningitis. So any family contact, everyone in the family needs prophylaxis. Child care or daycare, especially less than 2 years of age, and you want to prophylax them within 7 days of the contact. Anyone with direct contact with secretions within 7 days, anyone who's done mouth-to-mouth or intubated a patient without a mask. If you sleep in the same dwelling as the index patient, you need prophylaxis. And finally, they even defined passengers on an airline who sat next to the case during a trip which is over 8 hours, okay? So all these people need to be prophylaxed. These are the prophylactic agents of choice. You don't need to worry about doses, but we generally use rifampin in children, but the alternatives are ceftriaxone and ciprofloxacin. So if you had a pregnant teen that needed to be prophylaxis, you can't use either rifampin or cipro. In those cases, you would give IM ceftriaxone, okay? And again, just to remind you, these are the available meningococcal vaccines and the serotypes that they cover. But remember, the vaccine cannot replace chemoprophylaxis for close contacts. All right, second case is a previously healthy 15-month-old who develops a productive cough, high fever, and respiratory distress 2 days after mild cold symptoms. On exam, he's moderately ill. Temp is 39.5, respiratory rate is 60, has decreased breath sounds in the right lung and has nasal flaring, and the chest x-ray shows a right middle lobe infiltrate. So what's the most appropriate initial therapy for this child? Ampicillin, clindamycin, cefazolin, nafcillin, or vancomycin? Okay, very good. So ampicillin, this is community-acquired pneumonia in a previously well child. So the first-line agent to use in the hospital setting is IV ampicillin or IV penicillin. Third-generation cephalosporins would also be okay, but it's recommended that we use these only if the child is not fully immunized, if there is high-level pneumococcal resistance in your community, or those with life-threatening infections, including empyema. So for a complicated pneumonia, if you suspect a resistant pneumococcus, then you can use a third generation. But generally speaking, first line, ampicillin or penicillin is fine. If it's a school-age child and you're concerned about an atypical pneumonia, then you can certainly add a macrolide. And then if you have a child who is severely ill and you're at all concerned about Staph aureus or MRSA, then at that point you can add Venco or Clinda, but it is not used routinely right off the bat. Once you have a bug, if you have a bug, which we rarely do with with bacterial pneumonia, if you have a pen-susceptible pneumococcus, then certainly you should use ampicillin or penicillin, and these are the alternatives listed here for pen allergies. You know, again, the top of the slide is cut off for some reason. I'm not sure why. For invasive disease, but not meningitis or a resistant strep pneumo, then we would use a third-generation cephalosporin, such as ceftriaxone. Thank you. All right, and the alternatives there, again, high-dose ampicillin, and then in rare cases where we would have to use levofloxacin, clindamycin, or vancomycin. So once again that you have a bug for a group A strep, you're going to use penicillin or ampicillin. If you've isolated MSSA, you're going to use cefazolin or oxacillin. And again, if you've isolated MRSA, vancomycin or clindamycin if it's known to be susceptible to clindamycin. Okay, the next case is a 12-year-old boy with a 10-day history of sore throat, dry cough, and fever. On exam, the child is well appearing, has a temp of 39.2, respiratory rate of 28, and scattered rales bilaterally. And this is the chest x-ray. What's the most likely pathogen in this child? TB, Mycoplasma pneumonia, strep pneumonia, strep pyogenes, or Staph aureus. Okay, very good. So this is atypical pneumonia. So the next question is, what's the best test to confirm or to make the diagnosis of Mycoplasma pneumonia? A bacterial throat culture, a blood culture, a nasopharyngeal swab PCR, a single IgG and IgM specific titers, or cold agglutinins? This one's a little tricky as well, because what we do in real life doesn't always match what we should do. All right, so, okay. So the right answer is C, actually nasopharyngeal swab PCR, and this is why. So PCR for Mycoplasma pneumonia is now available. The sensitivity and specificity appears to be very well, 80 to 100%. And what they say is that a positive PCR from the nasopharynx with a classic clinical history suggests causation. You have to be careful because the PCR test can persistently be positive for weeks to months. So you really need a classic clinical history to go with it, okay? The problem with titers, so IgG and IgM, which we do all the time, and we get into trouble doing them because invariably the IgM is positive and the specificity is about 50%. So half the time, IgM is going to be positive regardless. So it is a horrible test. The best way to make the diagnosis is by illustrating a fourfold increase or seroconversion from a negative IgG to a positive IgG. But again, in real life, we rarely do that because we want to make the diagnosis acutely. We don't want to wait 2 to 4 weeks to make the diagnosis. So the diagnosis of Mycoplasma is problematic, and a lot of the positive IgMs are false positives. But if they ask you this on a test today, the preferred test is the PCR. And again, cold agglutinins are worthless. Sensitivity is only about 50%, and the specificity is even worse than that. All right, a 10-month-old seen in your office, a history of fever to 103 for the past 3 days. She does not attend daycare. She's playful, and the exam is unremarkable except for the high fever. There are no ill contacts. What's the most likely virus causing the child's fever? The Parvovirus, HHV6, EBV, CMV, or adenovirus? So again, this is a 10-month-old, which is a clue. Okay, very good. So HHV6, which is the cause of Exanthem subitum or Roseola. So the classic history is 3 to 5 days of fever, maybe some mild URI symptoms, maybe some cervical adenopathy, and then you usually see the rash after the fever resolves. Complications of Roseola include febrile seizures. This is probably the most common cause of febrile seizures in young infants. It can rarely cause meningitis and encephalitis, especially in immunocompromised children. We now know that this virus, HHV6, not only causes Roseola, but is a very common cause of fever in young children. This landmark study from Rochester in the early 90s showed that about 15% of children who presented to an emergency room with fever, about 15% of them had HHV6. Most of them did not have a rash and presented just with fever. So this is a very, very common, probably the most common cause of fever in young children less than 2 years of age. These are some of the findings that we see with HHV infection. As you see here, it's not only fever, they can look pretty sick. Lymphadenopathy is common, otitis media is common, febrile seizures again, and rashes may or may not be present. The classic Roseola history really occurs about a third of the time. The peak age is between 9 and 21 months of age. Just about every child gets infected with this virus by the time they are 2 years of age. There's no seasonal predilection to it. And these are, again, the most common symptoms: fever, fussiness, URI, rash, classic roseola, and a visit to the physician. So those kids that you're seeing in your office who have no focus, who look pretty well, and just have fever and nothing else, the first 2 years of life likely have HHV6. All right, case 5 is a 30-year-old teacher who calls your office seeking advice. She's 10 weeks pregnant, and there's been an outbreak of slap cheek disease in her school with some cases in her classroom. And she's asking for advice. What's the best advice that you can give her? Advise her that the risk to the fetus is low. Recommend a dose of IVIG for the teacher. Recommend a dose of IVIG for the baby after birth. Or recommend that she takes a leave of absence from work until the outbreak is over. Okay. Yeah, we don't generally recommend teachers take leaves of absence because parvovirus is so common, it's there all the time. But there is another important reason. The right answer is A. So let's talk about Parvo B19 a little bit. So about 50% of children have been infected with this virus by the time they are 15 years of age, therefore they are protected. And 50 to 80% of adults are protected against this virus because they've already been infected. This is usually seen in late winter and spring. It's spread by droplets, and the transmission from a contact is about 50% with a household contact. In a school or daycare setting, it's anywhere between 10 to 60%, depending on the study that you look at, and nosocomial transmission has been documented. So these are the manifestations. The most common manifestations is an asymptomatic infection. So most people who become infected with parvovirus are not symptomatic. Slap cheek disease or fifth disease is the most common manifestation that we see. Remember, this is a common cause of transient aplastic crisis that Aaron Flack talked about yesterday. This can cause stillbirth, high drops, and congenital anemia, and it is a cause of anemia in immune-suppressed hosts. Again, most people are totally asymptomatic. There are 3 stages here. The first stage occurs 4 to 14 days after incubation. This is the period of transmittability. So this is usually during the prodrome before they've developed a rash. This is the period when they are contagious. And it may be unrecognized. They usually have mild symptoms, fever, headache, GI symptoms. They're viremic during the stage, and this is the stage where the virus infects the erythrocyte progenitor cells, and they develop IgM. So this is when they're contagious. So this is an important cartoon here. So this is when they're excreting the virus. This is when they're experiencing the non-specific illness and when they are contagious. But as you can see, by the time they develop the rash of fifth disease, the slap cheek disease, they have already cleared their viremia. They've already developed antibodies. So at this stage, they are no longer contagious. So by the time they develop the rash, they're not contagious. So that's not going to help to take the teacher out of the classroom when the child has already developed a rash because they were contagious the 2 weeks before that, okay? So this is stage 2 when they develop the rash, the classic slap cheek, but again, they've already cleared their viremia. This is the classic fifth disease. And then stage 3 is when they develop the lacy reticular rash, usually on the extremities. It's maybe pruritic. It can come and go over 1 to 3 weeks. And they can also have mild arthropathy here, which is much more common in adolescents and adults, okay? And this is the classic lacy reticular rash that we see. So again, at least 50% of pregnant moms have already been infected before they became pregnant. The likelihood of infection after a close exposure is between 30 and 50%. So they've estimated fetal loss following infection during pregnancy is from 2 to 6%. So when you combine all of these, the overall risk of fetal loss due to this virus is about 1 to 2%. But again, because children were contagious before you know that they have the virus, it's very, very difficult to control this. So what do we do about infection control issues? Well, children who have erythema infectiosum, the slap cheek, they are not contagious and they may go to school or daycare. Okay, so we don't take them out at that stage. However, children hospitalized with transient aplastic crisis, if you remember the figure that I showed you during that, they are contagious. So if they are hospitalized, we do put them in droplet precautions. And again, with pregnant women exposed at home or school, given the high prevalence of infection, the high rate of silent infection, and the low risk of adverse events, we do not routinely exclude teachers and nurses from the workplace. We can offer serologic testing to offer them reassurance. So if you did have a pregnant mom early during pregnancy and she was really worried that she was being exposed, you could check an IgG early in pregnancy. If she's positive, which 50 to 80% are going to be positive, you can reassure her that way. If she's negative, you can follow her with fetal ultrasound, but that's the most that we generally do. All right, so case 6 is a 6-month-old baby born to a woman with HIV infection, and she has a 3-day history of URI symptoms and cough. Today she's developed a high fever, and on exam she's mildly tachypnic, but otherwise has no focal findings. And the chest x-ray shows an interstitial diffuse infiltrate. Pretty bad. Appropriate interventions at this point would include all of the following except obtaining a viral respiratory panel, obtaining a blood culture and treating with ceftriaxone, administering high-dose IV trimethoprim sulfa, sending a serum HIV antibody test on the infant, or sending an HIV DNA PCR on the infant. So remember, this is a 6-month-old born to a woman with HIV. Okay, very good. So you would not send a serum HIV antibody on a 6-month-old because it's very likely to be positive because mom is known to have HIV, so there's transplacental transfer of IgG from mom to baby. So that test is going to be positive. It doesn't tell you whether the baby is infected with HIV. But you're going to presume this baby is infected given that chest x-ray finding. So certainly obtaining a viral respiratory panel to try to identify a virus is a good idea. You want to get a blood culture and treat with antibiotics. That's a good idea. This could be PCP, which is the first manifestation of HIV at this age, so treating with IV Bactrim would probably be a good idea as well. And then finally, you want to confirm the diagnosis in the baby, and the way we do that at that age is with an HIV PCR test, such as a DNA or an RNA PCR. So generally, we screen for HIV in older children with an HIV 1-2 antigen antibody combination immune assay, and this is a screening test. However, this is not helpful in babies less than 18 months of age because of the transplacental spread of IgG antibody. So we use nucleic acid tests, either a PCR DNA or an RNA, to confirm the diagnosis of HIV in young infants. So again, maternal antibody can persist for 18 months. So we cannot use antibody tests the first 18 months of life. Even the Western blot, remember, that's an IgG test. So we do not rely on serology. So in babies less than 15 months, the recommendation is that we do a DNA or an RNA PCR test at 14 to 21 days, at 1 to 2 months, and at 4 to 6 months. And you also have the option of testing the baby with a DNA PCR right at birth. And then if you want to confirm the baby is or is not infected, usually beyond 18 months, it's okay to do an antibody test. About a third of babies are PCR positive by 48 hours, and sometimes that's why we do the test right at birth. So how do we definitively exclude congenital HIV in babies less than 18 months who was not breastfeeding? Again, we rely on a DNA or an RNA test, and 2 negative tests separated by 1 month, with one of them beyond 4 months of age, definitively excludes HIV. Or 2 negative antibody tests beyond 6 months of age. And of course, no lab or clinical evidence of HIV. So transmission of HIV from mom to baby usually occurs in utero or perinatally. The risk of transmission if mom and baby are not treated with antivirals is about between 20 and 30%. Remember, this can almost completely be prevented if mom and baby is treated with anti-HIV medication. Transmission can also occur through breastfeeding, through blood products, IV drug use, as well as sexual transmission. These are the common clinical manifestations of HIV, which we rarely see today because we've almost completely prevented perinatal transmission of HIV by treating mom and baby. But these are the common clinical manifestations: pneumocystis, lymphoid interstitial pneumonitis, and then just general failure to thrive, lymphadenopathy, hepatosplenomegaly. And remember, these children, when we used to see them, used to commonly present with recurrent bacterial infections in the first year of life, especially with strep pneumoniae. These are some of the immune defects with pediatric HIV. They're usually lymphopenic and have low CD4 counts. They also have T-cell defects. They don't have normal cytotoxic responses. They don't have normal responses to antigens and mitogens. And these children used to have very, very high specific antibodies, IgG, IgM, and IgA antibodies, but they did not respond well to vaccines. So although they were hypergamma-globulinic, they were not functional. And these are just to remind you of the normal CD4 counts in young infants. One of the things about the HIV epidemic is that it taught us what the normal CD4 counts in young infants were, and they're much higher than in older adults. So that the first year of life, a CD4 count less than 1750 is not normal, less than 1,000 in the second year of life, and you don't get to normal adult CD4 counts till beyond 6 years of age. Antiretroviral therapy, they're very unlikely to ask you about on the test, just because guidelines are constantly changing. But generally speaking, we like to treat HIV-infected children with HAART therapy. Certainly babies less than 12 months of age, we're very aggressive about treating. We treat children between 1 and 3 years of age if they have symptoms or if they have evidence of very high viral loads or very low CD4 counts. And then in older children, certainly if they have symptoms and based on their viral loads and CD4 counts. PCP prophylaxis is still very important. We usually begin Bactrim prophylaxis at 4 to 6 weeks of age. However, you can stop this when criteria for presumptive or definitive exclusion of HIV has been met. Certainly after an episode of PCP, you want to continue prophylaxis and for low CD4 counts and percentages. Okay, so the last case is a 3-year-old previously healthy boy who had a swollen lymph node on his right face for several weeks, has been otherwise asymptomatic. He lives in a suburban area, is not in childcare, and has no known exposure to anyone with tuberculosis. You put a PPD on and it is 9 millimeters indurated, and his chest x-ray is normal. And this is what it looks like. And as you can see, he's pretty well appearing. So what's the best therapy for this child? A course of INH, rifampin, and pyrazinamide, a biopsy of the node mass for culture, a course of clarithromycin and rifampin, complete excision of the lymph node, or INH for 9 months. This is a classic history for what? Okay, very good. Most of you got this. This is non-tuberculous mycobacterial adenitis. And the way that we treat this is we completely excise the lymph node. Okay, so complete excision is curative. Antimicrobial therapy sometimes we use if they can't remove the whole lymph node. Sometimes the ENT folks tell us it's really dangerous to take out the lymph node because of the facial nerve. But antimicrobial therapy really does not help in this situation, and we really try to convince the surgeon to take out the whole lymph node, which is curative. You don't want to biopsy this because it may create a fistulous tract. Sometimes the diagnosis is not totally clear, but in this case, this is the classic history where the child has no risk factors for TB. It's always going to be a toddler. Okay, this is always going to be a child between 1 and 4 years of age that they give you on exam, and they're going to give you a positive PPD, usually between 5 and 10 millimeters. So it does not meet the criteria for TB, but it is a positive PPD because it cross-reacts. Okay? So testing for tuberculosis in children. So what children need to be tested with either a skin test or a blood test for TB? Certainly any child who has had a contact with a contagious tuberculosis case, any child who's suspected clinically or has a radiograph which is suspicious for TB, certainly immigrants from endemic areas. If somebody is HIV positive, they actually need a TB test yearly, and anyone about to start immunosuppressive therapy for anything such as inflammatory bowel disease or rheumatoid arthritis. So let's just spend a couple of minutes talking about interferon-gamma release assays. These appear to have similar sensitivity to the tuberculin skin tests. They are much more specific, however, because they don't cross-react with BCG, okay? These do not distinguish latent from active infection, so they aren't really different from a PPD in that regard, and they are preferred in asymptomatic children over age 4 who have received BCG. We don't have a lot of data using these in children less than 5, so we generally prefer to use the PPD at that age. So children 5 years of age and older, you can use these instead of a PPD if follow-up is unlikely. If the child has had BCG, intermediate results with these tests are fairly common, and you just want to repeat the test. And if the TST is positive and the IGRA test is negative, which sometimes happens, latent TB is pretty unlikely, and we usually rely more on the IGRA test. You can use this if the TST is negative, but you have a high clinical suspicion of tuberculosis, then it is okay to use an IGRA test. But generally speaking, older than 5, you can use either a PPD or an IGRA test. Less than 5, we generally still prefer the PPD. And anytime somebody's had BCG and is older 5, you really want to prefer to use IGRA rather than PPD. These are just to remind you the definition of a positive PPD really depends on the risk factors. So 5 millimeters or greater of induration is positive in somebody who's had a contact with somebody known to actually have tuberculosis or suspected to have tuberculosis. Certainly an immunocompromised child or a child who clinically is thought to have TB, then 5 millimeters or greater is positive. Children less than 4, anyone with a chronic illness or somebody who's exposed to TB, we use 10 millimeters and greater as a positive. And for somebody who's older than 4 years of age who has no risk factors for TB, we really shouldn't be putting on a PPD on those kids. But if you do, then it's 15 millimeters or greater is positive. Okay, so I would definitely remember these. Treatment of latent TB, certainly somebody with a positive PPD or a positive IGRA test without active disease, or a child exposed to an adult with active disease, we go ahead and treat them with INH for 9 months, 12 months if they're HIV positive, and 6 months of rifampin daily is an alternative. So anytime you have a case of tuberculosis in a child, that is a sentinel event. It means that they've been in contact with an adult who has active tuberculosis. And that's usually how we make the clinical diagnosis as well. You want to clinically make that call and treat them empirically till you've excluded tuberculosis. The clinical settings in which you are likely to see TB, where it might be a tough diagnosis, certainly a young child presenting with an aseptic meningitis. If there's an exposure history to a TB, you certainly need to take that into consideration. The diagnosis is not always clear-cut. We really like to try to culture the organism, first morning sputum times 3. Sometimes we get gastric aspirates or bronchs, and finally nucleic acid tests. Okay? So that is the end of the first part of PEDS ID.